right case selection. When Uli and I were talking last night at dinner, it's all about case selection, isn't it? You hear that all the time, the word case selection, but it is. And the idea is to do the right procedure for the right case. So, type 2 and type 3 is a separate discussion, but I want to focus on type 1. What happens to this socket? Because it's amazing to me how few people understand what happens to a socket. Amazing today. So let's take a look. Just as we just found out, does alveolar ridge resorption continue throughout time? Not if there's no pressure on the ridge. It may not be. Doesn't mean it doesn't happen. It's not automatic. You have, of course, the periodontal ligament, the source of blood supply to the buccal plate. The ligament is now gone. You just took the tooth out. And that is a major source of blood supply. The periodontal ligament is extremely vascular, different than what you see in a diagram in a book which just shows fibrous tissue like a ligament, because it's probably at least 20% by volume is blood vessels. That's what allows us to handle occlusion in our lives so well. The ability to manipulate the bone and moderate the bone and remodel it. So that's one. Number 2 is the periosteum. Now, here's where the fun starts. If you open a flap, what happens to that buccal plate? You've interfered with the blood supply. Now you say, well, Dr. Tarnow, look, here's my beautiful case. Look at the beautiful case. I opened a flap, look at my surgery. I took the tooth out, non-traumatically beautiful. I'll talk about that in a second. I opened the flap. I said, oh gosh, what did you do that for? Well, that's what I was taught to do. I broke a root tip, so I have to go open a flap. I said, okay. So if you open a flap and then the guy sutured it beautifully, that's ridiculous that you don't think that you harmed anything. If you open a flap, I am on a rampage. I am on an absolute rampage. I swear to you that I cannot see opening a flap to take a tooth out anymore. You as dentists, we as dentists, have to learn to use the socket as a wide open socket. That you have to see that as a wide open entry for you to get anything out, even if you break off the very tip of a tooth. You cannot start opening tissue unless it's impacted. You don't, and yet other things that are wrong that you want to correct. If it's there, leave it there. Now how many people, because you say, well, I put it right back. Look, I closed it over, look at my beautiful sutures. I say, great, give me your finger. I'll use Jorg since he's older than he's 65, he doesn't care about his finger. So you're not going to work anymore, it doesn't matter. At 65, you're right. So I'm going to take his finger and I'm going to cut it off. But look, I'm going to put it right back. How's it feel, Jorg? Feels good, doesn't it? Sure. How stupid is that? How silly is that? You're taking away a major source of blood supply and then you're supposedly reanastomosing it, but it doesn't happen right away. It's going to take 4 to 6 days for reanastomosis to take place. Even though you covered your wound beautifully, you sutured it back, what's left on the buccal plate? The endoceous marrow. And that's so thin, there is no real marrow. It's just a thin piece of cortical bone. So now the question is, how thick is your buccal plate? I know that's a very personal question. And I know a lot of people in Europe don't want to talk about personal things like that. In America, we always go up to each other, hey, how thick's your buccal plate today? So let's take a look. And this work was done here in Europe. Beautiful paper. So you take a look at one of the work, Mariano Sanz. It hurt me to read the paper, even though these are great researchers. The good news, that hopefully this will never be done again to patients, to human beings. Because they did this on 72 patients. Opened up anterior tissue to take teeth out and measure this buccal distance. Measure the bone. That hurts. Hurt me to read it. I haven't opened a flap, and I'm a pretty busy clinician. I have not opened a flap to take a tooth out, molar or anterior tooth, in over 13 years, since the year 2000, unless it was infected. 13 years. Everything I do is through the socket, period. And I say that even in molars, because I want to preserve the ridge. So how thick is your buccal plate? What did Mariano Sanz show? Look at these numbers. You've read this? 64% with 4.5 millimeters in thickness. That's thin. So there is no cortical, the cortical plate is thin and there's no marrow. In fact, it takes at least 1.5 millimeters to have marrow between 2 plates of bone. And it's almost never 1.5 millimeters. So you really just have a thin piece of cortical bone on the buccal. The palatal bone, on the other hand, has many times good thickness. So when we take a look at this, when we take a look at this, and then what about this? 23% was 1 millimeter. So 90% of our buccal plates, this is human beings, not animals, in the 6 anterior teeth was 1 millimeter or less, with most of them being 2/3 being 0.5. This is a problem. That's why we see such change. That's why Uli talks about the dark space and underneath and the depression there, and correctly so, especially if you've opened the flap. Buccal contour change. What's been out there? Let's take a look at some of the data. These are some of the classics. Do you want to know what happens to 6 anterior human being teeth? Human beings like us, 6 anteriors? Take a look at Lekovic and Kenny. They did it twice to check what happens with and without a membrane. But the control was open a flap, mark your buccal plate, and then pull the flap over with primary closure. That was the control. And then they reopened it in 6 months with markers. What did they see? The vertical change, along with most of these papers, were good. Minimal change, 1 millimeter. Not so bad. You can usually live with a millimeter. The world's not coming to an end. Look at the buccal lingual change. Look at this. That's what happens if you open a flap and you pull the flap over the socket with nothing else done except to clean out, and you just do primary closure. There it is. 4.4 millimeters, 4.5 millimeters. They did it twice. Don't do it again. Don't ever do it to your patient. What would you like me to do if you fell right now and tripped and you broke your tooth right now? And you came into my office. And you have vertical fracture. And you even broke it in half. Would you want me to open a flap to get your root tip out? Everybody who feels they want me to open a flap to get the root tip out, you raise your hand. It's your body, your mouth. Or would you rather I work through the socket that is sitting right there, a nice wide open socket? Let me guess what the answer is going to be. Stupid for me to even ask you, isn't it? Dr. Tono, why did you work through the socket? It's my mouth, you know what I mean? I don't want any flaps and sutures and stuff like that. Which would you want in your mouth? Silly question, right? I'm in your face on this. Don't open flaps unnecessarily, and you'll preserve the bone for yourself and for your patients, even in the non-aesthetic zone, as you will see. So let's take type 1 sockets. Type 1 sockets, everything's there. Here's a patient that has external root resorption. And we spoke about this with the endodontist. Take a look at the x-ray. Severe resorption. Now, it's not about endo versus implants. That's just a ridiculous discussion. They put me the past 2 years, I've been up against phenomenal endodontists. Endo versus implants. They make this whole controversy up. There is no controversy. Endodontics is superb. They have a higher success rate than almost anybody that does anything in dentistry. They're 97% today with microscopes, even if they start with non-vital teeth. So it's not the endo. You can seal an apex. It's what's left of the tooth. And aesthetically, are you going to deform the patient to save what's left? And is it strong enough to hold what's left? So instead of going in and violating this, we all looked at this and we had a big discussion about it, and we decided to take it out. And you can see we had this lesion here. So I took it out, and very conservatively, little papilla ripped here because of this, okay? But we do it very conservatively. Now this one was easy, because this one still was not fractured yet, is it? I'll get to the fractured ones in a minute. But this was an easy one. Now, how do we take a tooth out? I'm sorry to do this to you. You know, I'm so basic. But I'm going back to basics, because the basics are not being taught properly by 90% of those people in the world in schools today. They're taught if you break a tooth or do anything, you open a flap. Oh, open a flap. Let's go, doctor. Open a flap. Let's go take some bone off. Let's go get access. No way. That doesn't happen. The access is through the socket from now on. Number 2. How do you take a tooth out? Oh, we talked to the crowns there, put a big, nice forceps on, like a 150 or 151. Grab the tooth, grab the crown, and what do? Luxate. Buccolingual, right? Is that most of your training? Did anybody get that training, or was it just me? No, yeah. That's ridiculous. What are you doing? You luxate buccolingually until you hear a crack. What is the crack? It's either the buccal plate or a root tip. That's got to stop. Molars we trisect or hemisect. Bicuspids we bisect. We don't touch them until we bisect them and take that out. We just don't see whether or not we're going to fracture a tooth and then go worry about it. We prophylactically do that beforehand. By the way, let's go back for 1 second. Look at Schwab's article. Schwab, 5.9 millimeters. That was posteriors. I'd rather preserve that ridge. Now, what did I find when I went back and looked at this literature? I'm a student like you are of the literature. Most of you are students of literature, I know that. Well, I am too. As a teacher, this is what I read all day, and this is what I keep up with. When I went back and looked at this, I said, I don't always see this. I don't see 6 millimeters. Sharp was the one that got me going. Because I said, I don't see 6 millimeters of buccolingual change. Am I doing something different? And the answer is I was. I wasn't opening flaps, because when I went back and looked at all this data, and here's the key thing to take, if you see nothing else today, is that by not opening a flap, you don't see these changes. You don't see these kind of changes, with rare exception. This is what happens when you open flaps. All these papers open flaps. How come the ridge vertically was not bad? That's because the palatal bone was intact. And it wasn't always opened, and it was thicker. So the vertical height of the ridge doesn't get too bad, but the buccolingual dimension is where the change is because of this, okay? That's why the vertical is not so bad on the ridge, but buccolingual is. So wouldn't I rather have 5.9 millimeters back if I could, or at least minimize that, to put a molar in or a bicuspid? Of course we would. So let's do type 1. So we've got this patient under control. We're going to take the tooth out, and we put the implant in. Now where do we put the implant? We all know today that we should be placing it slightly to the palate. We go in the 6 anterior teeth. We go slightly to the palate for a couple of reasons. One, as you're going to see why before we finish today, I want you to put in a screw down temporary. In the aesthetic zone, I would prefer not a cementable restoration with all the Wadhwani's work and everything. We don't want cement in there during the healing phase. And we actually want to get some adherence, as you will see, of epithelium to the acrylic temporary. We place it slightly to the palate, towards the cingulum. Now sometimes we'll kick off this palatal wall because there's no reciprocation with the gap, and with the last few turns, depends on the shape of your implant, you might hit off the palatal wall, and the last few turns in, even though you're aimed at the cingulum, and you've done the drilling up the palatal bone and apex, you'll see the implant moving slightly at the end. You'll move slightly forward. You've all seen that? Yeah, why? Because you're hitting the palatal wall, and there's no reciprocation, so you're going to move a little bit to the front. So at least you wind up towards the incisal edge, but not out. If you were repeatedly getting implants coming out of the buccal of your crowns, you are in the wrong place. If you're doing it to yourself, don't do it. If you have somebody else doing it to you, meaning a surgeon, periodontalist, oral surgeon doing it to you or for you, and they keep coming out this way, have a discussion with him or her and get it changed. Otherwise, switch surgeons. And I'm being real honest, you'll have a much easier life. So, we like to come out the palatal area, the cingulum. Lyndon Cooper talks about 3 millimeters up from the facial tissue, 3 millimeters up, which is about the buccal crest, and 2 millimeters back from the incisal edge. That's a pretty good estimate. 3 up, 2 back. And I go along with that. And I think everybody that goes along with that today that's been involved with this. Now take a look at this x-ray on the right side. Oh, it went too deep. Huh? Oh, he put the implant in too deep. What's he doing? I thought he was a decent surgeon. That implant's perfectly positioned. Why? Do you see it below the crest? Get used to seeing that in this anterior teeth, especially the central incisor. What's the normal scallop of bone in a central incisor? Between the interproximal bone versus the mid-facial bone, the average distance is 3 millimeters. So if I'm placing it at the buccal crest for cosmetic reasons, to have a smooth emergence profile, which is where we're going, 3 millimeters up from the buccal tissue is about the buccal crest, I am automatically 3 millimeters on average below interproximally. That's a problem. Because now we have violated the interdental bone, whatever implant you use, period. So we have to learn to compensate for that. Now here we have, thank gosh, I'm going to be talking about single teeth today. My topic's not 2 implants in a row. That's a big topic, and we have a whole day of lecture on that. But when you look at this, the good news is that the bone is normal on the adjacent teeth. And you all know that that's what helps support the papilla. So single teeth, everybody wants to show you. So I'd like to show it too. Because the papilla, if it's there, and the bone is not harmed on the adjacent teeth, we're golden. And that's where we are. So we place it up, so that's what you're going to see. Now, what you're going to see, we then put a temporary cylinder on, all the companies have it, and then we take a shell and we combine the two, and this is what we put in. Something that looks like this. This is not a piece of garbage. This is not some piece of junk that you just kind of got the patient out the door with something to walk out with. This is well designed, it's well thought out, and it's well made. You, if they're the restorative dentist, if you take the time to do this now, your work is done. You're sculpting the tissue from day one. You're keeping the shape that you want. And so it's supportive of the free gingiva. The contour is similar to what the final crown will look like and be. It will give or take a little. This is what you want. And this is preventing the tissue from collapsing in. And it's a screw down. So here it is, day one. Minimally invasive surgery. This one was easy because the tooth was still intact. Here it is 4 weeks later. You see almost no change. Now this was without even a graft. I'll show you why we'll talk about grafting the socket in a minute, the buckle. But this was without a graft. Here it is 13 weeks later. Now she started, by the way, with some mild discoloration up here. She was always darker. If you go back to the original case, I didn't mention that. If you go back to the original case, she even had a darker area there, which is kind of interesting to begin with. So when you look at this versus this repeatedly, we went back and looked at our pictures, this repeatedly was darker than the other side. But nevertheless, I want you to take a look at this case. When you take a look, and here it is 4 weeks, here it is at 13 weeks. Now, you could say, oh, he picked his one case that looks good. I know what you're thinking. Oh, he's got one case. That's nice. No. This is what we are seeing repeatedly when we start with a buccal plate and the contour is properly there and everything looks good like it started this way. This is what we see. And this patient was pretty thin scalloped tissue. This was not thick flat tissue. This is pretty scalloped. So where are we going with this? When we put the probe onto this tissue, we see the probe. This is thin scalloped. What I'm trying to say is that this is what we see. If we didn't see this routinely, we'd stop doing it. We're in a pretty high profile practice in Manhattan. And where everybody gets sued for a little papilla is missing. I think I'm going to sue you, you know. Like my papilla's missing. That's worth at least $500,000 in New York City. Okay. So what you're looking at is something else that's very important. Notice the bleeding. This is why I don't want cement in there. This is why we like, even if your final restoration will be cemented, this is why we like to have a screw-down provisional in the anterior aesthetic zone. Because we actually got tissue to adhere, epithelium actually adhered right to the temporary. Can epithelium adhere to acrylic? Yes. It can adhere to any clean surface. So we just have to make sure it's clean. So we steam clean these before we put them in. You can Profi-Jet them, you can polish them, you can do anything. We have to make sure there's no rouge on it, make sure there's no powder on it. Let the tissue adapt to anything clean. Epithelium is amazing. So notice this gap is completely closed in, and you notice that there's no pocket depth there. But we got the bleeding. Now we just take this and capture the same distance. This one was done by Steve Chu. And here's the final crown in place, and you see the contour is minimally changed. When we look at this carefully, it's still a little dark there, but the contour is still there. It is not appreciably lost. When we measured this compared to the contour outside, this was a ½ millimeter. And so notice that the bone is still there because the adjacent teeth were healthy and never opened up. My papilla were never opened up. And here you see the contours, and we basically have something that looks pretty natural. Let's take a look at this patient, high lip line. These are all high lip line patients. Every one of these will be high lip line that I'll show you today, where it's critical to have this. This patient has thicker flat tissue. This is an easier case, but it came in with a fracture, as you see here. So we take the tooth out. Now here's the first thing. The tooth was fractured, but what you see is we have different forceps now. The Salvin Corporation has them, called Deep Grippers. Titan has them. I don't care where you get them, but you can't use the 150, 151s anymore. Those are for horses, okay? You're not treating horses. So you get these that can go into the ligament space a little, and a lot of times you'll save a lot of time and energy. Now, how do we take teeth out? It's not buccolingual, minimal stuff like that, a little, but not a lot. It's rotation and out. And not just the centrals, that's true of all teeth. Rotate and out. Molars, we trisect, and we take the roots out separately that same way. Rotate and out. That's the way we take teeth out. Rotate and out. Rotate and out. Not the big buccolingual. A little bit, but not much. And so here I was able to grab this without a problem. I'll show you what happens when we can't in a few minutes. So we put an implant in again to the palate. Now we add that supportive. This is not a piece of junk. This takes a little bit of time now, but you are now capturing the exact shape you want the tissue to heal. You don't have to sculpt it later. You don't have to push the tissue out later. Instead of putting a healing abutment on and letting everything collapse in, and then pushing it out 3 months later with your temporary, causing blanching and discomfort for the patient, and chair time, take the chair time now and you're done. And that's what we want to do. So we picture this on, and we put this on, we got the right shape. But now, how do you put a graft in if you want to put a graft in? What we do is after this is completely done, finished, as you see here, take it off, put a straight healing abutment on, and then you place your graft in.